Good morning, everyone. I hope you're having a good meeting. Well, it is my sincere pleasure to introduce our Peter Safer Memorial Plenary Speaker, Dr. Mervyn Singer. Mervyn is a professor of intensive care medicine at the University College of London. He is also the director of the Bloomsbury Institute Intensive Care Medicine. Dr. Singer attended the medical school at St. Bartholomew's and received his MBBS and MD, the equivalent of our PhD in the US, at the University of London. He was named a Fellow of the Royal College of Physicians and a Fellow of the recently established Faculty of Intensive Care Medicine in the United Kingdom. I think we're all in for a treat to hear Dr. Singer's talk, 213 an ICU Odyssey. Dr. Singer's approach to his professional work can, I think, best be described as Renaissance. He has been a principal investigator of several multi-center, multinational clinical trials, such as the Pac-Man and the Corticus studies, as well as more recently the Promise, ProSafe, and Leopards, and several other studies with cool names like that. He's the author of papers and books on tissue oxygenation and sepsis, hemodynamic monitoring, infection, and many other topics in critical care. He's also the lead author of the Oxford Handbook of Critical Care. So for these reasons and many, many more, he's really the perfect person to put current critical care into the context of the historical good and bad that our predecessors have accomplished. So please welcome me in inviting Professor Mervyn Singer, our colleague, to give this plenary talk.
Hi, good morning, ladies and gentlemen. Great pleasure to be here, and thank you very much for coming at this ungodly hour in the morning. Without further ado, a bit of rousing music. It's a sort of great honor and a privilege to be here today, and hopefully for the next few minutes I'll give you some thoughts to take away. Apologies to Stanley Kubrick. Thomas Paine was an Englishman, and he wrote this pamphlet, famous pamphlet, Common Sense, addressed to the inhabitants of America, on the following interesting subject. So, with apologies to Thomas Paine, this is hopefully common sense from another Englishman. One with perhaps some royal pretensions, delusions of grandeur. I'm going to demonstrate that critical care has come a long, long way. Most new ideas have already been thought of. Less is often best, and the message of jumping hard and then perhaps sitting back on your hands. I'm going to make a plea for healthy iconoclasm, challenge dogma. And I'll demonstrate we still have quite a way to go, but we are getting there. I'm going to be gently provocative. Hopefully I want you to go away. It took people in the UK a lot longer to work out what that picture was about. But I want to be gently provocative and hopefully give some messages for you to mull over. I'll start with Daniel Boorstin. He's a Pulitzer Prize-winning historian who said the greatest obstacle to discovery is not ignorance, it's the illusion of knowledge. So we're now at 2013 and we look back 10, 20 years and laugh. And I'm sure in 10, 20 years' time we'll be laughing about what we did now. So intensive care has followed this route, and I'll briefly track through it from the early stages, way before it became recognized as a specialty in its own right. I'll talk about the brave new world of the 50s, the 60s, the dark ages, because I think we'll look back at the 80s and 90s and see a dip in our performance. I think we have entered the age of enlightenment. We're still working our way through it, and we're on the road to nirvana. We're not quite there yet, but eventually I think we'll get there. So critical care has come a long, long way. And the modern origins of critical care are traced back to the polio epidemic in Copenhagen in the 1950s. And this man, Bjorn Ibsen, was the senior anaesthetist, and he wrote this landmark paper about how they managed their polio victims. And he described critical care, a place where you could gather the sick patients, monitor them, observe them, look after them better than they would have been looked after on a general ward. You can see here, tracheostomies were done under general anesthesia, cuff tubes were used. They used initially medical students, they paid them to bag the patients, and then the following year they introduced mechanical positive pressure ventilators instead of the iron lungs. They found that secondary shock was now a phenomenon. They didn't die of respiratory failure, they had cardiovascular complications. And the concept of being a multidisciplinary specialty was demonstrated here, bringing in physiotherapists to prevent atelectasis. 34 of them were active during this period. And it wasn't just the physical therapists. They got other groups in the hospital to help. The tracheostomies were fairly rudimentary, and they gave all manner of problems. Sliding up and down, going against a wall, obstruction from secretion, splitting of the tube. They called the otologists, the ear, nose, and throat doctors, 1,500 times in 4 months at night. That's about 100 calls per night. We had trouble getting ours out for one call. Many strategies we embrace as new have actually been thought of long ago. ECMO. So we're all familiar with ECMO. It's been around. It's recently gained new interest. But look at this video, 1940 from Russia. Rousing music.
I should like to tell you that I have seen some of the experiments shown in this film actually carried out at the All-Russian Physiological Congress. As you can imagine, technique is everything. A substance which prevents clotting is introduced into the animal's blood. The dog is under an anesthetic. It doesn't feel pain. The experiment begins. All the blood is drained off through the carotid artery. The heart has stopped. The dog is dead. The auto-ejector is being attached before starting the revival. 10 minutes have elapsed since the animal died. The blood removed from the animal is pumped back into its vessels by the auto-ejector. The artificial blood circulation gradually induces the heart to start beating again. The heart's action begins to be normal. The respiration is gradually restored. We can now disconnect the auto-ejector and leave the organism of the dog to maintain life with its own resources. The dog is still weak and can't move. After 10 to 12 days, the dog returns to its normal state.
Wow. perhaps there are other things that await rediscovery. John Harvey Kellogg of the Battle Creek Sanatorium and Cornflakes wrote this paper in JAMA, 1888, Oxygen Enemas as a remedy for certain diseases of the liver and gut. It may be advantageously used in all cases where there's a disturbance of the normal interchange of gases in the lung, as deprives the system of its proper amount of oxygen. It's at once apparent that the introduction of a large amount of oxygen into the portal vein ought to help a feeble, overworked, or disabled liver. And it's been done. This is 2000 from the University of Massachusetts. They put into the small intestine a tube which bubbled out oxygen, and it got into the bloodstream. Here they reduced the FiO2 to 14%, and you can see the arterial oxygenation was improved. Let's wind the clock a bit forward to the Lancet, 1916. Tunnicliffe and Stebbing, the intravenous injection of oxygen. So they gave, through a peripheral vein, quantities ranging from 500 to a litre at the rate of 600 to 1200 cc's per hour. Cyanosis, the dyspnea attending it, are rapidly relieved. They began at 500 mils an hour. The more cyanosed the patient, the better the result. And you can go faster. The cyanosis is reduced, the rate can be diminished. Here's a case. One of malignant disease of the mediastinum. The woman was deeply cyanosed, had life-threatening dyspnea, which were only very partially relieved by inhalation of oxygen. She was treated by intravenous oxygen, continued for an hour. The cyanosis was immediately relieved. The dyspnea was relieved for a week. Her condition improved. So I'm not recommending you go home and try it, but it's interesting. No reports of harm. What about blood transfusion? Again, this came from London, 1829. An obstetrician, James Blundell, who, through this gravimetric device, transfused his patients. George Cryle from the Cleveland Clinic came up with a more sophisticated way of delivering the blood, but it didn't really take off. People didn't embrace blood transfusion. Here, again from the Lancet, end of the First World War, Dr. Robertson described, in cases of severe primary hemorrhage accompanied by shock, blood transfusion frequently produces an immediate and almost incredible improvement. But again, it didn't take off. ABO recognition, beginning of the century, Rhesus, 1937, Coombs testing, described 1945. However, even by the beginning of the Second World War, blood transfusion wasn't being used. This document from the UK Medical Research Council looked at the management of wound shock at two periods of the Second World War. The first during the Blitz in London when it was being bombed, and the second towards the end of the war in the front line in Italy. Often transfusion was resorted to only after other measures. The other measures were leaving the patient alone. You put them on a heated cradle, you didn't undress them, and you gave them a bit of morphine. And that was the treatment of shock at the beginning of the war. But after these measures had failed, then you could try some blood transfusion, but given slowly and in small amounts, seldom used prophylactically. Early transfusion was regarded as dangerous because of the likelihood of renewing bleeding before the surgeon was ready to deal with it. But rapid, large transfusions overburdened the circulation, dilated the heart, caused pulmonary edema. Transfusion reactions were common, thought to be harmful. It was thought useless to attempt the resuscitation of a moribund patient. However, by the end of the war, we can see that treatment in those early days was often misdirected and even harmful. Avoidable illness and loss of life were the result. Showing from the Italian series, there was an improvement in outcome. Wounds were examined now early, treated early. Undue warming was rare, and most important, transfusion was given earlier and more freely. This came out recently in the Journal of Trauma, looking at how much blood was given to combat victims who had major bleeding. And you can see this big jump going from World War II right through to the recent crises in Iraq and Afghanistan. And they made the comment that the average percentage of survival for massively transfused patients is 93%. That's remarkably good, isn't it? With increased survival comes an increase in the number of blood products being used. It's the highest ever compared to historical amounts. So getting there early, life-threatening hemorrhage, blood is life-saving. Clearly, once the patients are stable, giving blood may be less beneficial. But again, this message of jumping hard. What about resuscitation? It's a great honor and a privilege to be giving the Peter Safar Memorial Lecture. And that man is Peter Safar. Oops, sorry, I'll come back one. He described ABC in the mid-1950s. And that was a prolific time. His way of doing circulation was moving the arms up and down. At the same time, lots of other developments came. Paul Zoll in Boston invented the first pacemaker, the first cardiac monitor, and the first external defibrillator. And a few case studies in JAMA in 1960 from Kuvenhoven, Knickerbocker, and so forth talked about closed chest cardiac massage. But again, had they known the literature, they would have known it had been described 100 years earlier in Hungary. This guy, Balassa, he described a patient who had lifelessly collapsed. She became flaccid. Her cyanotic face became a mask of death. Her chest did not move. The pulsation of her heart ceased. He exerted a bellows-like rhythmic pressure to the front of her chest, and he saw the air coming in through fresh vinegar in her face. Different. He was close to suspending his efforts after 6 minutes, when suddenly she rejoiced me with a hasty and spontaneous sigh-like inspiration, supported by the movements of my hand, followed by a second breath, a third breath, and from the struggle of death, life began to smile. Why don't we write like that anymore? But we've learnt over the last few years that less is often best. So I'm going to touch on what I consider to be the dark age of critical care. Just because we could, we had the technology to do things, we did, because clearly it must be better to normalize people to what you and I walk around with. Fluid. They don't die of fluid, they need fluid. And so we made our patients look like Michelin men. And once they get better, don't worry, the fluid will go away. And they didn't die because of the fluid. Or did they? This was a post hoc analysis of the vasopressin trial done from Canada, the VAST trial, and they looked at the amount of fluid given to their patients, and they broke them down by quartile, and here they're adjusting for age, Apache score, and the severity of shock. And you can see, this is at 12 hours after the onset of resuscitation. The patients that did better, adjusted for severity, were those that had the least amount of fluid. Those who'd had much more fluid did progressively worse. 10 litres in 12 hours. That's a median score. Likewise, at day 4, the ones who got less fluid did better. The ones who got too much did worse, adjusted for severity. Same message comes through from the ARDSNet trial on giving fluid. So after the resuscitation period, if you managed to keep the patient fluid balance neutral, they did much better than those who were allowed to become just a litre a day positive for the next 7 days. So fluid is great, too much is bad. But the answers were there in the literature. This is the original description of ARDS by Ashbal, Petty and colleagues, Lancet 1967. And if you look down the right-hand column, look what the risk factor they identified was. Fluid overload, fluid overload, fluid overload, fluid overload. So the message was there early on. Likewise, in 2000, we saw definitively that too high a tidal volume was injurious. But again, going back to 1954, that was noted by Ibsen. Overventilation is harmful. So again, we don't learn necessarily the lessons of the past, or we have to belatedly rediscover them. Likewise, oxygen. Oxygen is great, the elixir of life. Too much of a good thing, perhaps, is bad. This recent analysis from JAMA showed that patients after cardiac arrest, the first blood gas, when they got back to the ICU, if they were hyperoxic, they did much worse than if that blood gas was normoxic. And in fact, the hyperoxics did as badly as the hypoxemics. Similar study from Todd Rice's group showing a similar thing. Oxygen, the maximum oxygen seen in the first 24 hours after cardiac arrest, they were treated with therapeutic hypothermia, did much worse, a 50% increase in mortality. But it wasn't just living or dying that was affected. Here they found that long-term neurocognitive abnormalities was much higher in those patients who had hyperoxia. So we have to not just slap a 100% oxygen face mask on them and forget about it. We need to think about the potential harm we're doing with every treatment, even though they're considered benign. And again, the message was out there years ago. This man, John Scott Haldane, was the father of the guy who introduced the Russian video, Jack Haldane. And Haldane Sr. was a physiologist at Oxford. And here, Lancet 1917 talked about the therapeutic administration of oxygen. It's well known that it produces at least temporary benefit for patients with big problems in their respiratory or circulatory function. However, sufficient attention hasn't been paid either to what benefit may be expected or how it can be best administered. In order to combat want of oxygen, it's evidently desirable to continue administration over long periods of time. But he recognized that it actually gave side effects. He called it pneumonia, we would call it pneumonitis. But pure oxygen produces pretty rapidly, and even at atmospheric pressure, a fatal pneumonitis after several days, occasionally produced in 4 days by a mixture of 80% oxygen. It's evidently desirable, therefore, to keep the oxygen percentage as low as possible and to know roughly what percentage is being breathed. So he was focusing on the lung. I think the same would apply with hyperoxia transmitted through to other tissues within the body. Less is best. So we've learnt, coming out of the Dark Ages, the age of enlightenment that we're in, that many of the things we took as gospel, blood transfusion, sedation, aggressive ventilation, were injurious. But why stop there? What about everything else we're doing? I could give separate lectures on inotropes, proton pump inhibitors, antibiotics. We need to look carefully at what we're doing at every level of critical care because there's benefit, but also the risk of harm. William Osler said one of the first duties of a physician is to educate the masses not to take medicine. I'll paraphrase that to say perhaps it's an important duty of ours to educate ourselves not to give medicines, especially when they're unnecessary or for too much or for too long a period of time. So yes, we have to jump hard on the sick patient, but then sit back. In the American Civil War, the northern side performed about 30,000 amputations in, as you can see, fairly rudimentary circumstances. If you look, I'll just pick one here. Amputation at the thigh. They had a 50% survival rate, which I hope you'll agree was quite impressive, judging by what was available to them. And they also noted the importance of jumping hard. So at the Battle of Antietam, 1862, 22% of those treated in hospital who were wounded in the battle died. But by Gettysburg, a year or so later, 9% died. What was different? Well, they recognized patients were dying of pyemia. They didn't know about infection. Pasteur hadn't come along. But they recognized this condition they called pyemia. The patients had high fever, and these patients nearly always died. And they recognized tetanus, again, a very high mortality rate. But they learned that if they chopped that limb off early, the patients did much better. So very aggressive intervention halved the mortality. And again, re-emphasizing, they performed it without blood transfusion, clotting products, fluid resuscitation, antibiotics, ventilators, renal support, infection control. Nothing that we hold dear. Same on the British side of the fence, the Battle of Trafalgar here. Admiral Lord Nelson, mortally wounded during the battle. But Dr. Beattie, the ship's doctor on board HMS Victory, in his medical report, which is in the National Archives, described 102 sailors on board the boat were wounded during the battle. He performed on board the ship 10 amputations. He reported later on deaths from gangrene, from tetanus. Of those 102, 6 died. Impressive. I'll move on now to a plea for healthy iconoclasm. We need to challenge dogma. Lenin, let's bring Lenin into the conversation. A lie told often enough becomes the truth. Or Stephen Levitt, if you've read Freakonomics, conventional wisdom must be simple, convenient, comfortable and comforting, though not necessarily true. So we're led to believe things, and I think it's a sad indictment of us all. I'm slightly better because I'm a bit anal. You know, we don't read the literature. We read the abstract, we hear the results, but perhaps we need to delve a bit deeper. This is a very interesting study, came out in Lancet Infectious Diseases from Dan Kett, who's in Miami, where they wanted to see if you followed the guidelines for treating patients at high risk of a multi-drug resistant pneumonia, would you do better? So they followed the guidelines of the ATS and the IDSA, giving 2 antibiotics to cover the gram-negatives and 1 to cover MRSA. So 4 units, 303 patients they looked at, and they followed the outcomes in these patients and found in both groups, those that did and didn't follow the guidelines, the empiric cover that was chosen was active in about 80-85% of the patients. What about the outcomes? Survival, 65% in the compliant group, 79%. Much, much better in those where they didn't follow the guidelines, didn't give the additional antibiotics. I'd like to mention this paper. This was my paper of the year, 2012. Why? Because it really challenged the dogma. It comes from the University of Virginia Medical Center, the surgical ICU. It's NIH funded, went through the ethics committee. And what they did was they read the literature and said, well, actually, it's not so convincing, this dogma about jumping in with antibiotics. And so they had a before-after experiment. For the first year, they did what they called aggressive treatment. Patient was suspected of having infection. They took cultures, and then they gave urgent or aggressively antibiotics. However, for the second year, they adopted a more conservative approach. Patient was suspected of infection. They took the cultures and then waited. I waited and waited until either the microbiology lab rang with, oh, the fluid you've taken out of this sterile fluid has got a gram-positive bug in it, or the cultures, ding, rang positive. Yes, we've got a gram-positive organism growing, or gram-negative, or whatever. So they waited until there was formal confirmation of a growth. Brave, eh? Would any of you do that? And what happened? Well, true to their word, they looked at about 250 patients each year, and there was a delay of about 24 hours in the meantime from fever to start of treatment between the 2 groups. The antibiotics, to my mind, a rather long duration in the aggressive group, and they reduced it significantly in those where they adopted a more conservative approach. Because obviously they knew they had more information as to what the bug was, the likelihood of giving an appropriate antibiotic improved by waiting. What about the outcome? 40% mortality in those where they treated them aggressively, 21% mortality where they waited. And when they adjusted for severity, there was a 2.5-fold increased risk of mortality when they treated aggressively. What about septic shock? Here they looked at patients with a mean arterial pressure below 60 who had a concurrent infection. The Apache scores were similar. There were about 100 in each group. And again, there was this delay in starting antibiotics of, here, median here, 16 hours. What about the outcome? 66% mortality in the aggressive group. Wow, 26% mortality in those where they waited. Now, I'm not saying adopt this, but it needs to make you think. Because they challenged the dogma and they got the result which is out with the dogma. So I think it's beholding to us, if we want to move forward as a specialty, to recognize these challenges and act appropriately. Because, and no disrespect to the Surviving Sepsis campaign, it's a message, yes, pick up the patient early, treat them quickly. And this is probably one of the most well-known slides or pictures in critical care. This, to be fair, rather biologically implausible straight-line relationship between delay in starting appropriate antibiotics after the onset of hypertension and an increasing mortality rate, a decrease in survival, 7.6% per hour of delay. But how many of you have read the paper from cover to cover? You've seen the slide, but have you read the paper? Because buried in the paper, it's there, there's this paragraph. These patients here constituted about 2,000 patients who were treated after the onset of shock. And so they excluded 558 who were treated with appropriate antibiotics before the onset of shock. And what happened to them? Their survival rate was 52%. So let's put 52% in there. That's interesting. The mortality, or the survival, was worse if you started the right antibiotic before the treatment compared to the first 4 hours after the treatment. So I'm not saying abandon early antibiotics, but we've got to challenge. We mustn't necessarily swallow everything wholesale. 2 + 2 doesn't necessarily equal 5. Just because an expert group, consensus committee, whatever, comes out with a statement, don't believe them. Check it for yourself. Verify the references for your sake as well as your patients. And looking at a little bit of maths and adding up, let's talk about religion. Another communist, or the guy who came up with the idea of communism, Karl Marx. Religion is the opium of the people. So I'll introduce you to a new religion, which I call bundleism. And with thanks to Bob Winter, who's in the UK, he's just a past president of the UK Intensive Care Society, so I'll acknowledge him for this slide. Would you all agree that 4 beers make the evening more pleasant? Yes? Would you agree that a bottle of wine makes the evening more pleasant? Yep. How about a good whiskey? True? So clearly, put them all together. What a good time we're going to have. Can I say the trial was attempted, but we all relate to that, don't we? So as Brian Kavanagh totally endorsed his talk yesterday, his plenary yesterday, we need to better understand what we're doing, look for what really works, and work from there onwards. I'd like to introduce you to this guy, David Eddy. He was a special healthcare advisor to Hillary Clinton. Great stuff. And he's got this concept, which I would commend to you, of EBID, evidence-based individualized decision-making. So EBM is the conscientious, explicit, judicious use of current best evidence in making decisions about the case of, italicized, individual patients. The practice of EBM means integrating individual, italicized, clinical expertise with the best available external evidence from systematic research. EBM is there to suit guidelines, or populations rather, and institutions. We want everyone to do this, do it. It doesn't suit the individual patient. Thank God our patients are different, otherwise we'd be out of a job. A robot could do our jobs. Eddie continued that EBM, or EBG, the guidelines, are put together by multidisciplinary teams, rigorous methods of doing so, coming up with generic guidelines. And they do affect the individual by influencing healthcare policy in general. However, EBID, the individualized decision-making, is done by individual physicians, using implicit and personal methods to make decisions about the individual patient and directly determine their care. So therefore, we have to integrate our own experience with the knowledge base that's out there that applies to populations. So we mustn't be held prisoner by these guidelines. We must be allowed to be flexible within it. We have a framework, a guideline, but we have to understand the physiology, the pathophysiology, the biochemistry, that we can adapt the knowledge base in general to the patient in front of us. So we need to tailor them, as he said. And it works in the other direction too. He notes that many problems fall through the cracks of guidelines. EBID is the only way to get evidence-based medicine to these patients. Physicians work on guideline teams, and the educational approach enables them to be better because you have to know the background knowledge. You're better able to integrate it and implement it. So it's a two-way process, which again, I think is really important. So what does the future hold? Last bit of the talk. Star Trek. That's where I get my knowledge from.
Kidney dialysis.
Dialysis? My God, what is this, the Dark Ages?
Oh, she's on dialysis.
Here. Do you swallow that? And if you have any problems, just call me.
How is he? Severe heart damage. Signs of congestion in both lungs. Evidence of massive circulatory collapse.
What the hell is that? What are you doing?
Tearing of the middle meningeal artery.
Simple evacuation of the expanding epidural hematoma will relieve the pressure.
My God, man. Drilling holes in his head's not the answer. The artery must be repaired. Now put away your butcher knives and let me save this patient before it's too late. Dealing with medievalism here. Chemotherapy. Fundoscopic examinations. Come on, Chekhov, wake up. He's coming around, Jim. Pavel, talk to me. Name, rank.
Chekhov.
Wow. Wouldn't it be great if we could do that? But I think we will get there. I'm really confident we will get there. What's coming through technologically will blow your minds away, and it's coming in the next 5-10 years. I'm confident to the bedside. We'll have bedside diagnostics. We won't need to send a sample to the laboratory and wait a couple of days for a result. We'll know a result within minutes. Early sepsis. We'll know in advance of the patient becoming really ill. Oh, they're showing signs of sepsis, and it will be sensitive and specific. Because we'll have this technology, we can better know how to handle the modulation of the inflammatory response, when we need to boost it a bit, a lot, or when we need to suppress it a bit, a lot. Because at the moment we adopt a rather naive one-size-fits-all approach. Give the patient the same amount of drug for the same amount of time. It's simplistic. In 10, 20 years' time, we'll laugh at our naivety. We'll have much better gas exchange strategies that are less injurious to the lung than conventional ventilation. Whether it's through intravenous injections or tubes up the backside, time will tell. We'll have better ways of looking after the kidney, or perhaps preventing acute kidney injury. We'll have better ways of feeding patients, so we'll know how much to feed, when to feed, and what to give them. Better protective strategies. I put there suspended animation. It will happen. we're playing and other people are playing with stuff at the moment that, again, you can literally hibernate, certainly rodents. Maybe we'll be able to do it to patients in the not-too-distant future. I think it's not just the front end of intensive care, keeping a patient alive. We need to augment their recovery, get them out of the ICU quicker, but also make sure they have decent long-term recovery. And again, there are approaches, metabolic and so forth, hormonal, that I think will allow our patients to get better sooner and survive their intensive care. Survivorship, I think, is going to be a key word in the next decade. I'll finish with this man, Jack Haldane. He was the guy who did the voiceover to the Russian video, the son of John Haldane. And he was the first professor of biometry here at University College, which is where I work in London. And he said this: "Theories have 4 stages of acceptance. This is worthless nonsense. This is an interesting but rather perverse point of view. This is true, but quite unimportant. I always said so." I'll leave it for you to decide where you want to place my talk. Thank you for listening.